She's going to speak to us about preventing and managing early and late postoperative hypotony.
Thank you. Good afternoon to all. Hypotony, coming to the most important topic. It's the most common complication after glaucoma surgery, especially glaucoma drainage devices and its associated vision threatening complications. We all know glaucoma drainage devices are for refractive glaucomas, and the decision to proceed with the surgery is most difficult depending on the patient's general health and visual potential. Some of the risk factors: younger age groups, the myopes, uveitis, ocular ischemic syndromes, and previous laser photocoagulation. So when do we expect hypotony? Immediate or the early postoperative period, when there is spontaneous tube ligature suturalizes, which usually occurs 5 to 6 weeks postoperative period, and sometimes late surprises. Conservative treatment, yes, in the first 24 to 48 hours, along with steroids and cycloplegics, elevates the intraocular pressure considerably, provided the anterior chamber is relatively maintained. If not, we have to think about other causes like your peritubal leakage, inadequate temporary watertight tube occlusions, or too larger venting slits. So let's see how we manage, how we avoid all this. An oversized tube track can cause excess aqueous humor to exit, resulting in hypotony and shallowing of the chamber. A 23 gauge needle, as it is shown here, sharp needle, provides an optimal size for an easy tube track construction and a snug fit insertion around the tube, and resulting in less leakage of peritubal aqueous or nil aqueous leakage. And you can see how snugly the tube is fit with a 4 millimeter, not more than 4 millimeters scleral track. And this also avoids the usage of patch graft. And always suspect an oversized tract when the tube, this is a small clue, when this tube goes freely without any resistance. And this is one case of poor scleral tract, and how we managed it because of the hypotony. An adjacent track is made with the same 23 gauge needle. And you can see the previous site, the original site, it is very superficial, and there is also a patch graft placed over it, which did not help in relieving the hypotony. So the tube is reinserted into this new track, and there are two other nylon sutures on adjacent areas of the previous track, which also did not help in relieving the hypotony. Then 10-0 nylon is used. The track is closed, the previous track is closed, and then the corneal patch graft is placed over it, sutured with the box suture, and then the conjunctiva was sutured. The patient is doing well now. And complete temporary tube occlusion with 260 Weichel sutures with a Supramed, which is now available, with one end at the tube plate junction, and other goes freely into the subtenon's space, where it can be retrieved in the postoperative period. And always check for complete temporary tube occlusion by inserting a 30 gauge cannula at the cut end of the tube and flushing saline over it. This is the postoperative picture showing the ridge of the episcleral plate and the Supramed in situ. And bending slits are always placed anterior to the ligature suture, so that there is a long end of the tube in case religation is necessary in the later postoperative period. It is a needle mounted on a 10-0 nylon, and it should be always placed on the straight lying area of the tube and not on the bent area, and avoid slicing through the tube. Again, it can cause excess aqueous flow resulting in hypotony. Spontaneous tube ligature, which occurs in 5 to 6 weeks post-op, it usually reforms well in 48 to 72 hours with conservative treatment. There is obscuration of the ridge of the episcleral plate with the capsule formation. If not, we have to take the patient for tube religation, as it is seen in this video. After a good exposure of the superior fornix, an L-shaped incision is given to the conjunctiva, and the tenons is very meticulously incised over the tube. The tube is exposed, the tube is slightly lifted, and a 6-0 additional Weichel suture is inserted and occluded completely to prevent excess aqueous flow and also to prevent further hypotony. The conjunctiva is closed with the same 6-0 vicryl as usual. This is the post-tube religation, the additional 6-0 vicryl there, and this is the post-operative period, 5 to 6 weeks, the absorption of the vicryl. And due to the meticulous handling of the conjunctiva is well opposed. Even after the resurgery, it is not retracted. And sometimes late unexplained hypotony, as it is seen here, with the tube corneal touch, shallow chamber and corneal folds, we have to go in for intraluminal stenting of the tube to relieve the hypotony, either ab externo or ab interno. Ab interno stenting with paracentesis and viscoelastic injected into the anterior chamber. A corneal stab incision is made next to the tube position. A supramed is measured with a 0.5 to 1 millimeter longer, so that protrudes outside the lumen of the tube. It can be retrieved later on in the postoperative period. And then it is slowly introduced into the lumen of the tube, and using a microvrexis forceps, it is fed into the tube. The advantage of ab interno being the conjunctiva is untouched and scar formation is also not there. So future surgeries, future repeat surgeries also will not be. And ab externo, after a good exposure again, the conjunctiva with a meticulous L-shaped incision, the tube is exposed, the tube is lifted, and 6-0 vicryl suture is placed additionally to occlude the tube lumen. This requires a posterior dissection at the tube plate junction to open up the capsule, so that at the tube plate junction we introduce proline. This is 3-0 proline, which is introduced into the lumen of the tube, and with a small bend at the posterior aspect, so that it doesn't extrude into the anterior chamber in the postoperative period. This occlusion of the tube is very important, very crucial in this, as while introducing the proline, hypotony can still occur, so we need to occlude with the vicryl. This is the post stenting with the suture in situ. Some of the cases where they managed chronic hypotony, like in this 3-month-old Barweld implantation, iWatch adjunction was done, and they IOP was successfully controlled through fine adjustments of the iWatch opening position, and there was complete resolution of choroidal attachment without any medication. And in 2 eyes with persistent hypotony, they went in for truncation of the wings of the Barweld with resolution of the hypotony. If there was a recurrence of intraocular pressure elevation, they went for reversal of tube occlusion, and they proved that it remained, the IOP remained both well controlled and sufficiently elevated. And managing leaks with cyanacrylate drops using a 25 gauge needle around the edges of the scleral flap after drying it at the tube insertion into the anterior chamber was also tried. So in conclusion, it is recommended to give adequate ligature of the tube, which is very, very important, and to use supramed suture to give tube blockage, adequate tube blockage, and to avoid larger incision, which can result in peritubal leakages. And 24 to 48 hours of conservative management definitely helps in initial hypotony period, but if not resolving, it has to be necessarily taken for surgical intervention to prevent any vision threatening complications. Thank you.
Thank you very much, Vidya. Just 2 things. Dr. Vidya had shown that peritubular leakage, where she made a separate entry. If you could see, there were already 2 sutures on either side of the tube. So surgeon for sure on table had some. Usually surgeons know on table AC is well formed. If there's some kind of peritubular leakage, you can notice it on table usually. Second thing is, she was also mentioning about venting slits closer to the vicryl suture. The idea is hypotony following venting slits are much more commoner than what we actually think. If you can place the venting slit more closer to the vicryl suture, you have space between your scleral tract and the vicral suture, where you can go in and put an additional vicral suture beyond the vending slit to reverse the hypotony. And third thing is, with the advent of this 3-0 multifilament supralon, so much of difficulty with ab externo stenting is